And then in 2003, 28 students arrived from all over Africa. And this building was not finished. So I'm sure Tendai remembers that when she arrived, there was a big pile of building rubble in the common room. And this lecture theater wasn't ready. So the first lectures were in the library. And then all the books arrived for the library, so the students had to catalog all the books. And they did it by hand, very efficiently. It took 2 days. And so the students really were involved in creating the institute, those 28 students. Tendai was one of those. And we went through a big learning experience that year. I can tell you one very funny event. At some point, the utensils from the dining area started to disappear. Knives and forks and plates. And so the staff came to me and said, "Oh, we have a problem. The cutlery and the plates are disappearing. What shall we do?" So we gathered the students. We said, "Look, we're being accused that we're not respecting the equipment. We have to clear our name. And so we have to inspect everybody's room and check who's got the glasses or the..." So we ended up with student representatives. We searched the whole building. Okay, I accompanied them, and it was quite embarrassing. Everybody had to let us into their room. We ended up finding 1 teaspoon in my room. So that was the end of that. And then we said, no, the students haven't done anything. And finally, the kitchen staff had to bring back the missing equipment. And we went through many events like this. But I have to tell you one other story, and this is about Tendai. Tendai, when she arrived, I hope she doesn't mind my saying, was a very shy young woman from Zimbabwe. And I don't think she'd been outside of Zimbabwe ever before. And so, but during the program, she obviously matured enormously. And on the day of the graduation, I came downstairs to this room. It wasn't as fancy as it is today. There were just very simple chairs and so on. But I came down at 9 a.m. and the graduation, I think, was at 2 or 3 p.m. And I found 2 people sitting here in this room. And they weren't young people. These were in their 50s or maybe older. And they were just sitting here. And I thought, I wonder who these people are. Never seen them before. So I went up to them politely. I said, I'm not sure. Are you in the right place? Because it's not even happening until, this afternoon. And they explained to me they were Tendai's parents. And they had traveled 2 days on a buses from Harare to Cape Town to come and see their daughter graduate. And to connect with Marcia said earlier, actually both of them were retired primary school teachers in Zimbabwe. And they were so proud that their daughter had reached a master's. Of course, she went on way beyond master's. Tendai went to University of Rochester. Sorry, University of Utrecht for PhD. Then to Rochester, right, as a postdoc. And Imperial College, and finally was employed by Public Health England as I forget the title, infectious disease modeler, but she's going to talk about that. And so she worked in Public Health England, the major health agency in the UK, for a long time, and then quite recently has moved to Pfizer as a senior something, which she will explain. So please join me in welcoming Tendai. Thank you. Can I put this?
Okay, good. All right. Thank you, Neil, for the introduction. I'm not so sure I can follow that at all. It's brilliant to be back again at Ames. So as Neil was saying, I can't believe it's 20 years ago, really, that we came in through the door. There was scaffolding, rubble everywhere. And to be back again here is just amazing, really. So thank you very much for inviting me. And I feel quite a lot of, pressure and, honor, really, to be representing my fellow students from that first year in sharing my story, as well as sort of hopefully inspire at least one person in the room. Okay. So sorry. Oh, the dreaded pointer. So today I'm going to share a story. It was a bit of a challenge for me to put this presentation together, really. My journey through my career is not exactly the most straightforward of journeys, but I also wanted to touch a bit on some of the opportunities that I sort of see across Africa in terms of what we might be also doing in the area of infectious disease modeling, which is sort of my area, really. So I'll try my best to sort of take us through a journey, weaving through my career and some of the things that's also, my views on this. I will start off, now I work in a very heavily regulated industry, so I have to start with a disclaimer. Whatever I'm going to present today is purely my views, right? Not the views of my employer, so we need to get that out of the way. Let me get started. So I'll start with this photograph here. So Neil will recognize the two people sitting on that photo. And surrounding those two people are 9 girls. So that's my family. Yeah. Right, so out of those 9 girls, I'm number 6. I'm guessing you can guess I'm wearing the sleeveless blue dress there when I was younger. This was just a few days before my wedding. And we had gathered all together in preparation for that. I was the first person in my family to go to university. Even though my parents were teachers, they had gone to teaching colleges. Some of you understand what I mean by that. 4 of my sisters had also gone through the same training, and they were also primary school teachers. Right. So in my family, teaching was a tried and tested, career path. Right. So when I became the first one to go to university, there had to be a compromise, right? I could go and learn my science and mathematics, but I had to also learn education. So when I started off in my career, I actually trained to be a high school teacher. That's what I trained to be. But I did a double major in mathematics and biology together with the training for teaching as well. That was the compromise I had to make with my parents so that they would let me go off and do the other bits that I wanted to do. Right, so my career started off, as I'm saying, that it started off in teaching, really. So I was teaching in Bulawayo, the second largest city in Zimbabwe. I taught at an all-boys school. I was very petite, And yeah, teaching teenage boys did teach me a thing or two, right? So my subjects were mainly teaching biology and mathematics, but this is sort of where my career started. Then AIMS was founded. I heard about AIMS from one of my lecturers who taught me at university. Encouraged me, the lecturer was actually from Madagascar. Right. And they encouraged me to apply to AIMS, which I did. And I had to then go back again to my parents to convince them that I was giving up this tried and tested career to go back to school, right? The compromise we had to make was that it was only for 9 months. However, as you would see through my story, it took me another 7 years in school before I went back to work, right? But you have to tell your stories as you go along to convince your parents, right? When I came to AIMS, this is the first time I was introduced to the field of mathematical modeling, really. So when I graduated from AIMS, as part of my project, the project that we do at the end, I was working with the then academic director at AIMS, Gareth Witten, and he was involved in mathematical modeling, but it was mathematical modeling within looking at the immune system, really. So once I graduated from AIMS, looking at this particular project, I stayed within AIMS to do a master's at UCT with Gareth Witten, but because he was academic director, I could get to stay at AIMS, work part-time as a tutor. So you might see in some of the 2004, 2005 photos I feature, because I lived at AIMS with the students that came in the following year. And AIMS being the, somebody said it's the place where, no minimum sleep, but maximum success or something like that, yeah. So I did my master's in a space of 9 months instead of 2 years, simply because I was here immersed with the AIMS students, working at the same time, at the same pace as they were, right. So this is sort of what it was like to be at AIMS for me. Oops. Which way am I pointing? Here? Oh, there we go. So what is this area that I was focusing on? So the area I was introduced to by Gareth Witten was an area of understanding how the lymphocytes, what we call CD4 and CD8 cells, how they are maintained within your body. This is cells, immune system cells, which are responsible for example, fighting against bacterial or viral infections. The particular interest for me was around HIV-infected individuals. So some of you may know that when somebody develops AIDS, right, they would have had their CD4 count drop below 200 count, right? And what we're trying to understand is, what is the virus doing, right, to these cells that is causing them to decline, right? What is causing them to progress to immunodeficiency, basically, which is sort of what eventually, causes the mortality for different individuals. We needed to do fundamental science, really, to understand what was going on within the individuals. So what started off as an AIMS project developed into my master's project, but also went on to be my PhD thesis, right? So I moved to the Netherlands because there's very few groups in the world which work on this particular field. One of the top groups was in the Netherlands. And when I went there, I was working with theoretical immunologists, right? They would do experiments in the lab, produce data, but they were struggling to explain what they were seeing in their experiments, right? They were trying to understand, are you getting production of cells from the thymus? Is that what is maintaining the cells in the body? Is there something else happening? Is there a reservoir in the spleen? Or are they sitting in the bone marrow? Are they going to the lymph nodes? They couldn't really, work out what exactly was going on in the system. Were the cells just multiplying and thereby maintaining a certain level. The virus will then come in, disturb this level, and then you get this sort of loss of cells. This is where now the mathematics comes in. So with mathematical models, the beauty of mathematical models is that you, on a computer, you are able to, perform multiple experiments, right, in a short space of time to try and see what explains the data the best, right? So we were looking at the bottom here, I just put sort of a schematic diagram of some of the models that we were looking at, trying to understand what is it that is responsible. Is it thymic output, proliferation, or is there some differentiation going on, right? How much death is going on within those, within the individual, okay? And by doing this, oops. Oops. Oh, sorry. Let me go back. Okay. So by doing this, this was very much the thesis that I came up with, and the conclusions of my thesis were really focused on quantifying, the dynamics of your naive T cells, right? How long are they living? How much are they being maintained? But one of the sort of funny things that came out of that thesis, apart from telling the scientist, your cells live for 8 days, right? The key thing that came out of it was that mice are not small humans, right? And what does this mean, right? A lot of times in the experimental sort of biology field, people were using mouse models, right, to represent what was happening in human beings, right? We were able to show between experiments within the mice, as well as some studies in humans, that the two are actually not the same. You cannot use a mouse to represent what's happening within a human being, because the processes that are maintaining the immune system in the two are completely different, right? So we shouldn't be sort of making conclusions, right, on what therapy to give to HIV patients based on whatever experiments we are doing in mice. So that was one of the key outcomes of my thesis, outside of, quantifying exactly how the cells were being maintained. I'm really struggling with this. To the front? Yeah. Oh, here. I thought this front. Sorry. Okay, there you go. Right. So I was talking to some students over the last couple of days, and I was getting a lot of questions, right? And people were more interested in understanding, what to expect if you're going to be doing your PhD, right? So here I'm talking to those who are sort of not yet at that sort of PhD levels. Those who have done their PhDs already, probably some of these things will resonate with you. So I did my PhD in the Netherlands, and one of the things that was a bit sort of daunting was that suddenly you are now in this new world where you are now responsible for your own scientific research. You are the one in the driving seat for this particular work. So hopefully here I can sort of cover a few sort of tips really of, what are some of the helpful things that you might look out for in terms of, making success of your PhD studies. So do take advantage of, owning your own research. You can drive the direction in which it's going. It is going to be hard work. At some point, you sort of think this is really never going to end, really. You look at your thesis, by the time you submit it, you don't want to look at it anymore. But it is quite a fulfilling journey as well. Time management, right, discipline is crucial. Otherwise, you can sort of lose track of your project, and funding, right? You need to be completing your studies within a certain time frame. When you're selecting your PhD supervisor, right, one of the things that I did notice from fellow students, as well as from myself, your supervisor is really quite influential in terms of making or breaking your studies. For PhD supervisors in the room, please be gentle with your students. So I think it is quite important to get some feedback from other former students so that you know that you are picking the right fit for you. You are going to be spending a lot of time, right, 3 to 4 years with this supervisor, so you need to be a perfect match to make it work. If you're going to do your PhD in an international setting or even another city, it can be quite isolating. So it's quite important for you to immerse yourself in whatever societies are around you, other PhD students in your departments, what is going on. Have some kind of social life. I know at Ames it can be a little bit tricky. I remember when we first, in our year here, Iksan at some point had to lock the doors and kick us all out to make sure that some people had some sort of fresh air, really, right? So he would tell us to go to the beach. You open the door after an hour or so. So you do need to have some sort of balance between work as well as some sort of social setting as well. You need to lean on your social networks, your family, your friends, whoever. My family got used to me calling them. Each time I was having dinner, we would eat dinner together over Skype, because when you're coming from such a large family as mine, I was so used to having sort of a more communal type meal. When you're all alone, you do need to sort of find ways to keep yourself going. And then you also need to set yourself sort of mini goals, right, so that you can celebrate along the way. 4 years is a long time. Unless you sort of celebrate and take it in steps, it might become a bit sort of, you don't quite see where it's ending, right? So do celebrate along the way. Do take time to embrace your environment, go see new things, explore, learn new culture, which is also quite fulfilling in terms of what you're learning beyond just your PhD. Okay. The conferences, we saw the party we had on the first day, right? They are always great fun. So any opportunity to take part in those, do take part, of course, funding permitting. But most of all, do enjoy your journey. Okay. Right, so stepping back again to sort of my career journey, sort of leaving a bit the tips to the side. So once I finished my PhD, taking my knowledge in terms of understanding the immune system, I went to Rochester, New York, in upstate New York, to join a group which was the University of Rochester Medical Center, where they were focusing on trying to understand the innate immune responses to influenza A. So similarly to what we're doing to try and understand how the immune system responds to HIV infection, here we were more focused on influenza A immune responses, trying to understand how can we use therapies to try and make sure that individuals do not progress to worse outcomes, especially if they are vulnerable. And then, as you know, life happens, right? In my case, love happened. Then I need to sort of change direction a little bit. But this is not the reason I changed my research direction, right? It's just why I changed countries, basically. So I got married in 2011. And I needed to find a new role so that I could be able to join my family. I was also quite interested in exploring a new area, right, to understand more on a population level type dynamics. So I knew I had the skills to put together dynamic models, what we call dynamic models, using differential equations, right? Understand how different compartments within the body were interacting with each other, and how any changes might change what the outcome might be. So in my view, I wanted to sort of explore something beyond that. What would be the public health impact, right? So I was doing more fundamental science when I was doing my PhD, my first postdoc. Now I was more interested in the public health impact. I wanted to take my skills that I had developed, apply them to understanding how diseases were spreading between different individuals. So taking advantage of my knowledge of immunology, how the body was responding, how people might get infected from one person to the other, I went on to Imperial College, Niels Frommer School, where I joined a group who were focusing on trying to understand how tuberculosis was spreading within people who are homeless, as well as new immigrants in the UK. Some people might find it strange that we have tuberculosis in the UK, but we have the underserved populations, right, who don't necessarily have easy access to healthcare, who still have a huge burden of tuberculosis. So these are either recently arrived immigrants, you have the homeless individuals, people in prisons as well. So that was my focus area. One of the key challenges was really around the drug-resistant TB, which was starting to go up in incidence in the country. So this is where I now took the skills that I had, the mathematical skills, together with my knowledge of immunology, put it together to now understand how we could design interventions to make sure that you can control the spread of TB within the population. And within the particular project that I was working on was a project which had been contracted out to Imperial College by the Public Health England, which is a subsidiary of the Department of Health in the UK. So when you work for government departments, government department type projects, one of the key things that is quite important is to understand whether the intervention you are suggesting to them will be good value for money, right? So they have a responsibility to make sure that they are spending the public money in a cost-effective way. So you have to put together the population dynamics, the benefit to the individual, together with the economic benefit as well. This is how I got introduced to the field of health economics, right? So now I had my differential equations, but I needed to understand a bit more of the economic side of it so that you can put those two together, so that you're not just suggesting an intervention which actually cannot be implemented because it's too expensive. Yeah. So I went back to school part-time to learn a bit more, to upskill myself, right, to learn a bit more about this field of health economics. Right, so that was my time at the Public Health England, okay? Oh gosh, let's try this. No? Okay, so to give you a sort of like a crash course in what is health economics, really, I love to use this graph, especially with policymakers, because it's very friendly. You don't have to put too many equations on there, otherwise, people stop listening, basically. So basically, the idea with health economics is that you take, so you do know how your disease is spreading in terms of the number of cases, new cases that are coming up in your population, how many people need to be hospitalized, how many people are dying. That is all described by your differential equations, right? But with every individual who is getting hospitalized, there's a cost associated with that hospitalization, right? So the government has to pay for that individual to be in hospital. The treatment that they're going to have, there's a cost associated with it. In addition, for the individual, right, because they are sick, they have an impact on their quality of life, what we call quality of life. So quality of life here is what we call the QALYs, right? That's just your adjusted life years. It's a measure between 0 and 1, where if it's 1, you're in perfect health. When it's 0, you are dead. You can have conditions that can have a negative QALY, right, where the person wishes they were dead, basically. So that can happen. So it can go below 0. So when you're doing health economics or cost effectiveness analysis, what you're doing, you're trying to balance between the benefits of quality of life that the individual gets from your intervention versus how much it's going to cost for that person to gain that additional quality of life. In the UK, they put a value, right, on this QALY. They value a single QALY at 20,000 pounds, right? So any additional, if your quality of life increases by 1 QALY, the government is willing to pay 20,000 pounds for that intervention, right, to be implemented, okay? It looks like a lot, but once you do all the other math, it's quite, compared to other countries, it's quite limiting. If you look at the US, for example, it can go up to 150,000. Okay. So what you are really doing is making sure that you are, let's see, is this the pointer? Okay. So you have an equation here, which is looking at an intervention, B, versus A. Usually A is your current situation, what we call standard of care, right? So you compare the cost of doing the intervention versus not doing anything. You compare the quality of life gains of doing something versus not doing anything. And then you look at what the ratio of these two is. This is what is called an incremental cost effectiveness ratio, right? In ISA, if you've ever heard of the word ISA. And this ISA has to be below this 20,000 pounds per QALY for the government to say, yes, this is a cost-effective intervention, we will pay for it. If your ISA is above that, the UK government will not pay for it. So depending on the country you're talking about, the threshold will be slightly different. I'm just using the UK here as an example. So you can put these calculations on a quadrant, right, where you can plot your changes in cost versus your changes in your quality of life. And what the decision maker, the policy maker here, is trying to look for is usually these two areas here, right? Ideally, they want to be in this particular quadrant where something costs less to implement and gains better quality of health for the patients. So this is like the holy grail. You want to be over here, right? And if it's going to make the quality of life worse, so for example, if the treatment has side effects that might actually drop your quality of life, and it costs them more, then that is not going to be a recommended intervention. Okay? So this is sort of kind of a crash course of what health economics is. I'll talk more later about this in relation to South Africa and some of the developments that have been happening here. Oops. So I've been working in the area for the last decade of, population health, infectious diseases. So coming back to sort of the context of Africa indeed, there's a lot of things that we learned during the COVID-19 pandemic. One of the key things that came out of the pandemic, which was, I thought was brilliant, was that the public suddenly knew what mathematical modeling was, right? We were, on TV, suddenly there were celebrities, right? Everybody suddenly knew what R naught was. right? Before you had to make quite a huge effort to try and explain what is R naught, because people had never heard of that sort of concept, or understanding what you mean by modeling, really. So in a way, for the future infectious disease modelers, it's great that we had, this sort of situation that happened. I am not, downplaying, the negative impacts of what happened with the pandemic, but in the field of infectious diseases, in terms of putting to the forefront the importance of mathematical modeling, was one of the impacts. So mathematical models were used a lot in trying to predict what was going to happen next and inform, the public health interventions, really. Do we need to lock down? Do we not need to lock down? Which groups might we be putting in isolation? That kind of thing. And when all the chaos was happening during the pandemic, one of the things that sort of got me so excited, right? The world was quite depressing at the time, but I got so excited one day when I got invited to a webinar, which was talking about a study, a project that was being done together at AIMS Rwanda. Neil was one of the co-authors on this particular paper. Some of the people who were in this room yesterday, they saw a video talking about this particular work. So this work was around methods of testing individuals, right, but in a much more cost-effective manner. One of the key things that was seen during the pandemic was that you needed to do mass testing of individuals to identify who is infected. Then you can isolate those individuals, put together sort of, control strategies based on that. However, when you are in a low-income setting, right, mass testing is not a viable option, right? So you need to find other ways of achieving the same goal, but with less, right? And this particular study was looking at ways of sampling, really, or testing, where you needed, I don't know if Neil remembers how much less number of tests that you needed to do, but it was magnitude, right? Less compared to just saying everybody needs to test. You test people in groups, and in that way you can work out quickly who needs to be isolated and who doesn't need to be isolated, right? So this here was, to me, very important because, one, you were identifying a key problem within a local setting, right, where you knew that doing like what everybody else was doing just wouldn't work, right? You have a local problem, you are trying to find a local solution, right, relevant to your own setting. And this was a great example of that. And the beauty of this particular study is in that this works even very well at low prevalences. At low prevalences, doing mass testing is very wasteful, actually, because you're testing a lot of people who actually are not even infected as well. But the performance of this method, even at low prevalence, for me, it was just so impressive. So it was quite an exciting thing to see. Even better, one of the things also that got me excited about this particular situation was the involvement of the government, right? The backing of the policymakers in order for this to actually work. There was a lot of buy-in from the government. They were more than happy for it to be implemented right across the country in a in a small pilot first, and then more widespread. And also the similar intervention was also implemented in Uganda as well, where they were also looking at similar applications, but also looking at how cost-effective it was. So this particular group went on to actually calculate the cost-effectiveness of that pooling strategy as well. But this is quite important for, I think, for us scientists to understand, right, when we do research that is relevant, that is actually answering the problem, right, that the policymakers have, policymakers suddenly listen. Okay. Right. So when you are an infectious disease modeler, there is, you do need to focus on, what is the current problem, right, that we are being faced with. This particular table here was quite interesting to me because it shows this from the WHO, and it shows the changes in terms of the top 20 causes of deaths, right, across different ages across Africa, right, in 2000 versus 2019, okay? So sometimes we have a tendency to stick with the familiar, right? So I know malaria, I'm going to stick to malaria, right? In 2000, it would have made, a lot of sense to be focusing on, say, malaria or HIV. But you look at how diseases progress with time. A lot of research has been done in a lot of these diseases, and because of certain strategies that have been put in place, the availability of vaccines, for example, they are no longer the leading causes of death. The priorities have changed. So as scientists, we also need to be evolving with the environment that we are in. So we need to be constantly looking at what needs to be addressed right now, okay? So you now have, your neonatal conditions still dominating, but you also have a lot of lower respiratory infections being a key problem for us to also try and resolve. So we need to have sort of that agility of being able to look at what is the current problem, what do we need to be solving in the current situation, especially if you want your policymakers to listen, right? And also for them to provide the funding, right? Talk in the language that you're providing a solution to something that matters to them in the current situation. Right. So going back to the health economics, the cost effectiveness analysis example that I was giving before, another area that also got me quite excited was around the introduction of the NHI in South Africa, right? So I don't know for South Africans, this is sort of is not news, but here in South Africa, they are going towards universal health system, very much similar to the your UK type NHS. So the vision, of course, is around making sure that everybody has affordable access to healthcare, which is absolutely brilliant, right? So you want to make sure that you are strengthening your healthcare system so that everybody can have access. And my understanding is that they already passed the bill last year in June. And this is a key milestone, right, that paves the way for this to be implemented. There are several advantages to having universal type care. So care can be quite comprehensive and accessible, right, for any different sort of levels of income. You can also have quite a good focus on preventative care, which you see in countries where they have similar type health cares. So because the system knows that if we do not resolve, say, obesity, right, we are going in the future going to have a lot of problems with diabetes. So there will be a lot of focus on preventative type healthcare programs. You also have improved negotiating power. So when it comes to negotiating, say, for access for treatments, because you're now trying to negotiate for a much more larger population, right? You're a much bigger organization. You now have much more, because of the volume, you now have much more better negotiating power. So that sort of makes it even more affordable on the local space. However, there's challenges, right? I know a lot of people who always say that, in the UK, free healthcare and it's brilliant, but nobody ever looks at the challenges around actually what this brings. And one of those challenges, ensuring that there is sort of equity and equal access right? You have a lot of different diseases to deal with. How do you decide where to focus your resources on, right? There's always, within the health economic space, a debate around access for treatments for cancer patients. So if you have, for example, a cancer patient with 6 months to live, right, versus vaccinating a child against immunization, right? If you do cost-utility analysis, you tend to get more quality gains for the child because they are going to live a full life, right, compared to the individual with only 6 months left to live. Now, for the family of the individual with cancer, they will pay anything to have those 6 months of life added for their relative, right? How do you decide? Who decides, right, whether you're going to spend that money on the cancer patient or on the child against measles? So this is a dilemma that South Africa will need to deal with. They will need to come up with their own solutions. Looking to other countries will be helpful, but it would need to be tailored to your own setting because it will be a challenge. There's also a limited budget, right? We all wish we had done limited budgets that we can spend on everything we want. So cost effectiveness will be key. You can only pay for the things that brings you, the biggest bang for your buck. There might be also issues around the waiting times. Lots more people access, lots more waiting times. So that will need to be carefully managed as well. With a one sort of healthcare system type, you also have limited options. Your GP is your GP. You don't have the option of going and sort of, getting a second opinion in the next province, because you need to stay within your local area because that's your assigned area. So these are just a few, it's not exhaustive, the list of the things that you might have to keep in mind as you bring into force this new healthcare system, but it is absolutely brilliant. Right, so what are some of the challenges that I see in terms of doing infectious disease research in a sort of an African perspective? One of the key problems is around funding, right? We need funding to be able to do some of the studies that we want to do. So a lot of this is from a paper, a recent paper from, I think, 2019. And what the authors found is that you have a lot of centralization of funding in more the higher income countries. You also have issues around access to sort of the high impact journals as well, right? So all these things will need to be addressed in order for us to make strides in this area. On a national level itself, there needs to be a change in sort of the attitudes towards research and how research can actually change the way we live our lives, how it can inform policy. Politicians don't necessarily always value, right, the inputs that you get from research. And on a more local level itself, institutions need to put more priority on research. There can be quite a big focus on teaching, for example, churning out students, but not much focus on giving the lecturers some time to do some research work as well and supporting any of the projects that they might be looking at, right? There are some ethical issues to be addressed, right? We always need to respect people's data. So that also would need to have some regulations put in place. Resources, as well as limited training as well. And in a separate study, I also found this table, which I found to be quite interesting as well, where I think there's sort of opportunities for us to sort of tap into here. So this table here is summarizing, right, across different regions of Africa, how much funding, right, is coming from collaborations between academic and corporate, academic and government, as well as academic and medical. As you can see here, nothing barely touches, 20%, right? I think we need to do a bit more in approaching, other stakeholders outside of the academic field in order for us to boost the funding as well as boosting our research as well. Okay. So what are some of the things? So this is just my sort of rough thinking of where can we be focusing on in terms of improving our research so that it's much more impactful. One of the things that I wanted to highlight is that whoever owns the data drives the agenda, right? So there's a lot of data that comes out of Africa, but we don't necessarily always write the stories that follow that data, right? So we need to make sure that the data ownership, right, driving the research agenda, right, remains sort of aligned with the priorities of the sort of African communities. There's also needs to be focus on data-driven research as well. In order for our research, it is a bit of a pity sometimes, right? If you're trying to convince politicians, policymakers, about your research and how impactful it is, if it's not supported by any data whatsoever, right, it's a difficult story to tell, right? So focusing on data-driven research is quite important. And also we need to understand for our stakeholders, what are their priorities, right? So if you go study a disease that's not necessarily on the agenda for the Department of Health, surely that discussion about getting funding is not going to go very well. So we need to make sure that we understand what our stakeholders' priorities are in order to shape what we are also going to be focusing on in our research. We need to have that collaborative culture built between the corporate sector, the government, as well as academia, right? Academics, we love to work in silos, right? We like to talk to our own, get lost in all our theorems and proofs. We do enjoy that, right? But we also do need to step outside, right, and interact with the community. For us to be impactful, we need to go out and be able to talk to our politicians, to the doctors down the road, to understand what their challenge is and how we can work together to solve it. And this requires for us to develop a type of communication, right, which resonates together with those individuals. When you talk about your research, you need to be able to explain it to somebody who is a not mathematician, right? We are more used to writing our scientific papers, writing every single detail that, of how we came up with the equations, how we solved them, the proof. But we also need to be able to translate our research into a language that is palatable with grammar who is walking down the road as well. And that needs quite a lot of communication skills. I'm glad Rejoice is working on those sort of community outreach type projects. I think they are quite important for us to, in order for us to work together. Take advantage of the opportunities to collaborate internationally. There's a lot of learnings that we can have. We don't have to reinvent the wheel, right? Implement things that have already been solved elsewhere, but make sure that they're tailored for the local setting as well. We need to make sure that we optimize whatever data. Data is, like gold, really. Let's value it, get the most out we can out of the data that we have, but also make sure that we're improving the quality of the data that we are collecting. Otherwise, it's of no use to us, really. There's been a lot of AI talk around. I had to put in AI, right? Right. So we need to sort of take advantage of all this sort of, valuable, the computing power that we have now, right, is just brilliant. We can do a lot more than we used to be doing before. So let's take advantage of that in trying to tackle our infectious diseases problems. And also, in terms of the struggle around lack of training, I think we have now access to loads of training platforms online, really. I think we need to take that opportunity to upskill ourselves to learn a bit more, right, on what other additional skills do we need in order to deliver the most impactful research. Okay. Now, going back a bit to my career journey. In 2020, January, I then decided that I wanted to to dip my toe into the corporate world. So I'd been working at Public Health England for about 8 years or so. And I was focusing mainly on particular groups, right? The homeless, the prisoners, that sort of thing. But I wanted to sort of explore a bit more. How can I impact public health on a national level, on a global level, really? How can I do this, right? So what I then decided to do is to look at where I could have opportunities to be able to do this. So one of the things that in our group within Public Health England, we had a PhD student, right, who had a pharmacy degree, but she was doing a PhD in public health. She finished her studies and then went over to work at Pfizer. And then when she came back to collect her stuff really from the office, we started to have a chat. And she told me a bit more about what they were doing within Pfizer. Then I started to realize, oh, actually, this actually might be what I'm actually looking for, right? So I wanted to be able to now work within a space where I could be affecting on a country level at the time. That's where I started off, just doing research which has an impact on the UK population as a whole. So I applied to Pfizer, and I got accepted. And one of the things that I did realize was that when I got there, that it was a beast. When you think you sort of know, I thought I knew things, right? Having spent years working on infectious diseases, but understanding how the organization works, how large it was just like a beast. It took me, about 6 months just to understand who does what and when. So it was quite a huge and massive learning curve. It didn't help that I started in January. March, the pandemic hit. That wasn't helpful at all. So oops. So I was having several conversations with students around the last few days, and some of them were wondering, what is it that a mathematician does in a pharmaceutical company anyway? Right. So I put this slide together here to show you the different, so this is how sort of you develop a medicine or a vaccine, right, in very basic terms. And I put in at every stage where mathematics, statistics would come in, so that you can get an idea of that it's everywhere, basically. Right? There's so many places where you can have implementation of mathematical models. So starting off with the basic science. So if you're trying to identify what molecule, right, is actually going to be able to block certain, a certain response, right, in order, that might be a candidate for developing a medicine, right? You need to understand the molecular as well as your cellular level models, really. You can even go down as, the genetics. You need to understand quite a lot of different biological states, really, in order to work out this sort of basic science here. And you have a lot of statistical analysis that goes on as well in terms of translating whatever data you have there. A lot of AI insights being used quite a lot these days, right, to identify which molecules to target, or which target sites on a virus, for example, you need to be targeting in order to stop replication, right. A lot of bioinformatics as well, for those who are familiar with bioinformatics. So this, for example, is similar to what I was doing during my PhD, right? Understanding how the immune system responds to, say, if you treat somebody with HIV, how that's going to change your immune response. So this is sort of where it comes in. Then when you're actually trying to develop the model itself, so these are sort of our preclinical studies, really. Then you're trying to look at your within-host dynamics. If you do give a person this drug, what immune response do you expect? If it's a vaccine, what immune response do you expect? And this helps in designing the clinical trial itself, right? You need to anticipate what is the dose, right, that you're going to be giving this individual. That is all done by mathematical models. Then you have your sort of phase 3, 2, 3 studies, where you're looking at your safety and your efficacy, and you're gathering your data that you need for your regulatory licensing. And that also requires a lot of statistical inputs, AI inputs, as well as more mathematical modeling as well. Then comes to the area which I spend a lot of my time within Pfizer. And this is around the health technology assessment as well as the reimbursement part of the product. So we are now looking at the commercial launch. Now you have your drug. You have shown it is safe and efficacious. You've got your license. Now you need to get the product to the patients, right? And here you're now going to have the discussions with what we call the payers, right? The government, the Ministry of Health. In order for them to buy the drug, you need to be able to show what value, right? Going back to that cost effectiveness that I was talking about. What is the value that this drug is going to bring me, right? So we can develop mathematical models to show them, to quantify that quality of life gain, right, versus the cost of the drug. How is this going to bring you a value? And then we have here the final stage is what we usually call phase 4. And this is also monitoring safety, more long-term safety and continued marketing as well. And this is where you get a lot of real-world evidence coming in and analysis of that evidence to understand how the drug is performing in a real-life sort of setting. Because a lot of this stuff that happens here is more in a controlled setting because it's a clinical trial. Okay. Right, so what is it that I do on a day-to-day basis? So I belong to what is called the Value and Evidence Center of Excellence. And our responsibility is really to ensure that patients have affordable, timely access to medicines and vaccines, right? And also we have a focus on sort of innovative value and evidence solution. So within our work, in addition to doing our day-to-day sort of reimbursement work, we also do engage in sort of basic science research, looking at new methodologies for analysis of our data, or new methods for modeling certain diseases, for example. So we do some research as well. We cover many different types of therapies, including inflammation, immunology, oncology, vaccines, rare diseases, internal medicines, as well as hospital products. My current focus in the last 4 years has been either vaccines or the hospital products. So this year, some students asked me to go in a bit more detail what it is that I actually do. So my work is multi-factored, really. So it does include some generating some mathematical models. This only comes in around here. So designing and executing our global health economic models, right, that we need in order to convey our value messages for reimbursement. We do some publications as well, just like other scientists as well. But a lot of my other work, as you can see, the rest of it is outside of that modeling work. So as a director of HTA, Value and Evidence, which is now my current role, this role, so I say to you that when I first joined Pfizer, I was working more on a country level, impacting access to medicines for the UK. After 3 years, I then was invited to join the global team. So I work within Pfizer Global, supporting several countries. So all countries within the EU, the UK, Canada, New Zealand, Australia, as well as the emerging markets as well. So basically everywhere where Pfizer is. And what my key role is to lead on the evidence generation strategies. So this is usually mainly related to our real-world evidence studies. So we have a lot of databases available with data, planning and making sure that we get the right data that we need to support the asset that we are about to launch. My role is also quite a strategic role. In terms of the actual trial designs themselves, I need to be able to anticipate what type of evidence would the government want to see in order to justify paying for this particular medicine. So I need to think of that well in advance when we are designing our trials to make sure that our trials are set up to provide us with the right endpoints or the patient population that we need to launch that particular project. I also lead and coordinate any inputs from the local countries, as well as supporting all those countries across the globe in their HTA negotiations, in their HTA dossier development as well. I already mentioned that I'm also responsible, I'm the subject matter expert for my asset for any of the economic models that we are developing. So I manage a team of vendors who do the modeling for us, but you need to be to know your stuff in terms of the economic models. If you are going to make sure that the vendor is delivering what is quality. Otherwise, it can go wrong very quickly. I do a lot of also stakeholder engagements, particularly the internal teams as well. So I work with a lot of different departments. So one of the things I was saying that Pfizer is like a beast, really. So what we have within the team and the cross-functional teams that we work with, I could be working with anything from the lawyers, or we could be working with the policy engagement team, the communication team. We could be working with our medical team, our field force, for example. So you need to be able to communicate with all those individuals in an efficient way. Okay. We also do external engagement as well, making sure that we are always up to date with what our stakeholders externally require and if we are solving those particular problems. Okay? Right, so I've talked about my journey to this point. But what I didn't share too much was the struggles that you face along the way. It all looks like it's all rosy and all fun and easy going. But there's a lot of challenges that we all face, particularly from a perspective of an African woman, really. So we have the challenges. Of course, the number one is always the financial struggles. In order for you to further your studies, you need to be able to somehow find the funding to do this. We were fortunate through AIMS to get some of the funding to do some of this work, but also because I studied in the Netherlands is a unique PhD system where you're actually an employee of the university rather than a student. So I got a salary instead of paying tuition fees. You also have a lot of social pressures, right, to be conformed to the stereotype, right? So I had this quite a lot, right? So coming from a family of all women, it was a little bit not very comfortable for people to hear that I was going to be studying a PhD in mathematical sciences, really. It is pretty hard. And once I had already also graduated and started working as a teacher, to then go back for another 7 years, the look on my father's face when I told him I was going to do a PhD for 4 years, right? It was, pretty much tell it all. Everybody's expecting you to already get married, have start a family, and stop this nonsense of going back to school, right? We all know what it is like. So there is always that pressure. So you need to be kind of a rebel, really, to I am not having this. I'm going to do what I want to do. And then the lack of role models. There's a saying that you can't be what you can't see, right? Some people agree with it, some people don't, but it is really hard to be what you cannot see, right? So we need to have much more role models. And lack of knowledge about opportunities. So it's not so much lack of opportunities, but actually knowing where those opportunities are. I was surprised at how much I didn't know. And then also inadequate communication skills, right? And understanding what different sectors need. We sort of spend a lot of time in the academic sector. We know a lot about academics, but we have no clue about what the industry actually requires. Networking as well. There's always this closed group that you struggle to break into. I had this in my frustration in academia was the closed networks, not being able to break into those networks. And the last one is around sustaining that growth, right? You can break into this career, but keeping it going can be a challenge. When the little baby is screaming and crying, you would really think, about quitting quite quickly. Right, so I've got a few last sort of tips on, from my experience, what I think worked for me, and hopefully it might work for somebody else. One of the key things is that you need to have a clear goal and a plan, right? And in terms of understanding sometimes it's not so clear what you want to do really. Do explore things like job simulations, right? The one I was saying that there's so many things available on the internet these days, right? There's things called job simulations where you can actually go through, I think maybe 10 to 12 hours or something. Then they take you through what a role involves. There's somebody sort of explaining to you your day-to-day job and see if you like it or not. Pfizer does this as well, so you can explore this website called The Forage. There's several companies on there who do this. And then also do try and work out what the path is going to be for you to reach your goal. One thing I sort of will confess to being is a LinkedIn stalker. So what I used to do is that I had an idea of where I wanted to be, but I had no clue how to do this because I had nobody that I could look up to. So I'd go on LinkedIn and look at the people who have done that and see how they ended up there, and then decide, okay, what am I missing, right, that I need to upskill on in order for me to get to that position as well. Do your research and understand the differences between academia, public sector, and industry. I've worked in all three, and they are very, very different. The CV you send to these three places is very different as well. So you need to understand those differences as well. Do look at identifying the skills that you already have. We underestimate the skills that we already have and how transferable they are to the next field. But you need to have the right language to transfer it to the next setting. And then upskilling. Once people finish their studies, they're like, I don't want to go back to school again. Right. I told that I did take night classes to upskill myself on health economics because I knew I was lacking in that area, and if I wanted to get to my destination, I had to do it. So between raising my 5-year-old at the time, full-time job, I also took additional modules from an MSc class to upskill myself. Self-funded myself, but it paid off. And also consider what is called a zigzag career. As you can see, my career was not straightforward. I've been academia, civil service. There is lots of things that you can learn along the way. When I was working in public service, I learned how the public servants think. Now I work in industry where I have to negotiate with the public servants, right? So do consider the values of doing that. And then build yourself a network. You all know somebody, surely, right? And LinkedIn is your friend. Right? Don't be afraid to contact people. You'll be surprised at people, how responsive they are. And then we also need to define your values and your priorities. This is very much about sustaining the growth, right? So before I was talking about just how to sort of launch your growth. So define your priorities, right? If your priority is family, stick to that. That is your priority, right? Don't be bending your priorities for somebody else. It can be hard, I know, but you do need to do it. With that, once you know what your values and priorities are, then look at what the company that you're looking at, right, what their priorities and values are, right? Are they aligned to yours, right? If yours is family, are they valuing family as well, right? What are their maternity leave policies, right? If you want to raise a family, right, you want to have 2, 3 children, don't be going to a company where they've only 1 week maternity leave. How is that going to work, right? So do also consider flexible working. One of the outcomes of the pandemic was suddenly employers realized that employees can independently work from home, right? Do value that as well. Consider also part-time or block working, so you can keep your career still moving by temporarily maybe taking a part-time role while you focus on family, for example. Always depend on your social network. Your friends, your family are really, really important for the success of your career. Find yourself some cheerleaders, right? You need cheerleaders. You need somebody when things are hard to really say you really are doing great. You need to find yourself a cheerleader. And also, more importantly, you need to find an accountability partner. An accountability partner is one you share your goals with, right? And that person regularly asks you where you are on your path to reaching that goal, right? Those people are very, very important. You want somebody who will tell you the truth, not hiding anything, okay? And never stop learning, really. We all need to keep on learning. There's always something new to learn. Right. Oops. Right. Finally, giving back. I get a lot of joy from giving back. Right. It's very fulfilling for me. So do consider being a mentor. My current job right now only provides me with about 5 days of volunteering, which those 5 days I'm using this week. And because of those 5 days, I used to be able to come teach at AIMS. AIMS Cameroon is the only place I've managed to go and teach a 3-week course. That was when I was in public service, when I was more freer to do a 3-week way, right? But right now, because I only have 5 days, I have to think about how I utilize those 5 days in my giving back, right? So I mentor, I help out students, you know, advise whoever I can. Also supervising students, consider that as well. And also make sure that when you meet a fellow, especially to the women, right? I'm not discriminating, right? Give positive feedback when positive feedback is due. Do say it, right? It's very important that somebody hears, that somebody believes them. Right, that really, they really think they're doing great. It makes a difference to a lot of people. And also working with charities or being a STEM ambassador is quite important. For some of you who know Alan Bearden and Tony, right? Right now I actually work very closely with Tony on Matea, a charity, and I'm one of the treasurers there. We met here at AIMS, and I'm still in contact with them, right? It's a charity that focuses on upskilling teachers across Africa. Okay. Right. So yeah, a big thank you for me. On behalf of AIMS 2003, 2004, AIMS has been a transforming place for everybody who you see on this picture. We are still all in touch. We have a WhatsApp group. I've been sharing pictures with them. And really from the bottom of hearts, the funders, everybody who has played a significant role in our transformation, we would really love to thank you. And I would like to finally say Siyakhula, and really wishing you all the best in your mathematical journeys. Thank you.
We just have time for questions. So let's take any questions from the audience. Everyone's exhausted. There's the question. Do you have a microphone, or can you bring it?
Thank you so much for such a beautiful, thorough, and amazing talk, and sharing amazing journey that you had. You told us about how you used mathematical modeling in your work. I wonder if you could say a few words whether or not mathematical thinking has helped you in other areas of your career or life outside of the explicit mathematical modeling.
Hello? Oh, okay, thank you. I'm not so sure we can get away from mathematical thinking, to be honest, right? It's pretty much part of our day-to-day lives. To me, especially when it comes to approaching problem solving, right? For me, it's always like you're putting together some kind of algorithm of some sort. So it's not, I can't really think you can switch it on and off as such. To me, it's really part of my day-to-day life. If I'm faced with a problem, I'm very methodological about how I'm going to tackle anything. In a way, I tend to think, what's the outcome going to be, and then work backwards as to what steps do I need to do in order to get to this particular outcome. Uncertainty is one of the things that I have to sort of grapple with myself, because in my mind, I know what uncertainty is, you know, how you look at uncertainty, for example, and it does affect the way I make my decisions, for example. So I do need to gather a bit more information before I make a decision about, you know, whether to buy that loaf of bread. I'm being a bit extreme here, right? But I think as a mathematician, it's quite difficult to sort of get away from that sort of mathematical thinking, even without being explicit about putting together a model. I hope that answers your question.
Thank you very much for this very inspirational talk. So I'm a mathematical modeler of infectious diseases myself too, and what I found the most difficult challenge is actually to get economic data on health economics. Now your CV showed you kind of worked on all sides. Mm-hmm. What would be your advice to get better public health data and actually kind of let our mathematical models thrive more by dipping actually also in the economic impact rather than things like incidence?
Yeah. So in terms of the economic data itself, there's quite a lot of publicly available data. In my experience, in any analysis that I've done, it's almost always has been publicly available data, right? Within the company, we cannot make anything public that's not yet, if it's still confidential, it's confidential. But within the government, when I was in government, a lot of the things were publicly available. So I think it's a matter of understanding where those sources are, right? So the UK government, for example, they do publish the prices, right, of a hospital bed. But not only that, they'll also tell you, for particular conditions, right? So you have, I don't know if you know about ICD-10 codes. So these are codes that are used to classify different diagnoses, right? So they do every year publish, they're kind of 2 years delayed, but every year they publish the latest cost for whether it's pneumonia, whether it's bacterial pneumonia or viral pneumonia, or if it's tuberculosis. For that hospital stay, they will publish the cost, but you do need to know where to find it, right? So when you work in the field, you sort of get to eventually know where to find it. In the UK, it's NHS Digital. This is where you get the data. In Germany or other places, they also have their sources. So I would suggest that probably look at the health economic publications that have been done, especially those that come out of the government institutions themselves, so like Public Health England. Look at the references that they are using as well, right? So majority of the time they're using publicly available data. If they don't, they provide the data in their supplementary as well. But there is sources, but they're not easy to find if you don't know exactly where to look.
Okay, I'm under instructions from Rejoice. I'm under strict instructions from Rejoice to close this because dinner is waiting. But let's give Tendai another round of applause.